You sit on underneath your butt cheek. So if we divide the leg in half and come in just a little bit and push up, there is ischial tuberosity. Okay, right there. So all you would do is, I would put a thumb on it, and then I would just put my tube right next to my thumb, and I would move around and make sure, okay, my thumb is lateral, just on the lateral side of the greater trochanter, of the ischial tuberosity, like this, guys. So here, so I find it, I'm gonna come a little bit to the side of it so that I have a treatment window, and then you can put your tube there and needle. It's kind of hard. I guess you could bracket it like that, okay? You can bracket it like that and needle up onto it. Very uncommon thing, I think. Let's see if we can find sciatic nerve. So I'm gonna ask my patient, I'm gonna kind of poke around a little bit. You guys might be able to feel it, but I want you to tell me if you feel something that feels kind of weird, like kind of nervy. Is that it or no?
Oh, yeah.
So it should be right in the middle, right? And it should run from right in the middle to pretty much right in the middle of the knee. So if we can find something nervy up top, and like I said, guys, you can give yourself like a 1-inch line just down the middle of the back of the thigh. And the point is, we don't have to know exactly where sciatic nerve is. When we needle our hamstrings, we're just gonna be off the midline. We're gonna come off and needle out. We're gonna come off and needle out. We're gonna come off and needle out. We don't really have anything exciting until, I would say, in the lower half of the leg, right? Femoral nerve starts to wrap around. So I'm gonna say in here is kind of a,
is it femoral nerve?
yeah, femoral nerve. If we needle, femoral nerve is like here. And so if we needle this way and we're too generous with our angle, then maybe we'll bump into like femoral nerve artery and vein. And so maybe this little inner part of the knee we want to avoid.
You want to say femoral nerve artery and then I think that's it.
Say femoral nerve artery vein. That's what we're trying to miss right there. We'll look at that when we look at adductors as well. But while we're doing this, it's fine. Okay, so we have sciatic nerve comes out pretty close to the ischial tuberosity. Okay, it's gonna run kind of. It usually runs medial to that. The sciatic nerve usually runs medial to hamstrings insertion. Okay, so. And then we've got most of our quad muscles that are originating off of here. Sorry, our hamstring muscles. Guys, I need more coffee. So medially we have semimembranosus and semitendinosus. So from here, we're gonna have semimembranosus and semitendinosus. Laterally, we're gonna have long head of biceps, okay? And we also have a short head of biceps. All right, and I would say this is a pretty crude drawing, but we're gonna hit him. You can make your patient hold your leg here, hold your leg here, hold it tight. Hold it tight. And we can get in and feel okay. Okay, so I would say from here and relax. But I want to stay off of that because underneath we have sciatic nerve, so we can come out to the side and needle anteriorly or a little bit laterally. Are there any long needles?
I think there's some.
I just need one.
You said that you don't usually needle on hamstrings just because it's not as effective?
I haven't needed to. I haven't had patients with that diagnosis. Whenever we are treating posterior thigh pain, usually it's like sciatica, like pelvis, low back. If someone comes in with hamstring strain, what's the first thing we do? Straight leg raise test. Oh, my hamstring hurts. Let go of the ankle. Oh yeah, it feels better. If you move the ankle and what they feel back here changes, it's not the hamstrings. So usually that's what you'll see with posterior thigh pain. So that's an important differential diagnosis. But if you need to needle hamstrings, you guys have a good picture. I'm going to go ahead, and I think it'll be efficient for our time if we, because this is easy. What's this? Make your calf tight. Make your calf tight. Push down into my hand. Push down. Push down. Okay. So there's gastroc. And guys, soleus is easy. We're just going to needle through gastroc and hit soleus. What's the rule here? We're going to come off the midline, and we're going to needle a little bit laterally to be extra safe and careful. So you've got gastroc and soleus. So I want you guys to try to hit these. You'll have to open up the lab manual. You can get TJ and me for help. You don't have to needle ischial tuberosity. Thank you.
I mean, you can also do like resisted medial and external rotation of the tibia with resisted flexion to find the muscles. I mean,
You
that's
can
another way to find
turn
it.
it and pull, turn it and pull. I think you're still going to turn them all on, but hold it tight. If I had to needle here, I would just take a sharp turn, but I think it's better just stay off the midline, okay? So you can bracket.
You need the ischial tuberosity.
Needle the ischial tuberosity. Medial to the sciatic nerve. And if we're smart, if I can just get that whole bulk into my fingers, we can get all of it, right? If I'll come off of the midline, punch it in, angle it medially. And if you wanted to, it's a really big area, you can pull it out and redirect, and we can pepper a little bit medial and a little bit lateral, hit some trigger points and move on, right? If I'm not sure if I'm hitting them both and I've gone lateral, then I can pull it out and go medial, and just to try to ensure that we're getting what we want to get. We're just not aiming it back towards the midline. So same thing over here. Lift up your foot a tiny bit. And relax. Probably about not quite midway down is a good place to find everybody. Lift up and relax. So once again, we can needle kind of medial to lateral and hope we hit everybody. Okay, okay, I'll take that. That's hammies done. How about gastroc and soleus? I'm going to come needle there.
Oh my god. This is probably the most sore muscle. I mean, if you
It doesn't have to be that bad. I don't know.
Gastrocs are probably the worst. Or yeah, I mean, have you had more? Okay, yeah. Choice. If you want people to practice, then.
Too generous, TJ. You know, as our mentor, you have to lead by example. You know that.
You can, yeah. So what you would do is,
I don't care.
within the gastroc, you can have them turn it on, and you know the fibers, how the fibers are. You can just palpate in this area, and we're looking for trigger points. You just have to play by the rules, which is stay off the midline. And you might as well like palpate around the midline a little bit and see if you can ask your patient, do you feel something nervy? You probably won't be able to detect a pulse down this far in that artery and stuff like that, but you should be able to find something nervy if you poke around enough.
How deep are you going with the gastroc?
You can go either you can angle towards the, I think just pinch it from the other side, maybe, and then you can go towards your fingers. I usually just needle in until, like, I'm analyzing the depth here, and I'm just like, okay, we need to go about that far, right? That's what I'll do. But if you wanted to pinch it from the other side, that might be even better, help you stay off the midline and give you a definitive ending point, right? And if you want to find good strong legs, you can see a good soleus.
You go like, you do soleus like lower, or do you go just like there?
Through there.
Wherever the trigger points are. I usually find trigger points in calf, sometimes in soleus too, and usually this is in like runners, or maybe some patient that has like neural pain. Yeah, or maybe a patient that has like neural pain and their muscles are tense because of that, like hypertonic because of that. And you can hit soleus. You guys know that soleus stays a muscle way lower than gastroc. Here's Achilles tendon. So this is all soleus too. I just like to needle efficiently, right? I'm just gonna boom, boom, probably done, probably gonna move on at that point. So, but you can poke around for trigger points, especially if patients like, my pain is here. Oh, that's soleus. Okay, like let's hit that point. You guys think you can do hamstrings? And I don't think you guys need to draw any of it. You should be able to imagine midline. You can put a thumb there or 2 fingers there, and then be like, okay, I'm gonna come off of that. You know what I mean? If you guys want to draw, you can.
I think sciatic nerve specifically is a thick band. If you try to go in, it will just deflect away. It's so thick.
Yeah.
That's
Can't
what they
you
say.
just like pick up, or not pick up, but like pinch around the hamstring when you're contracting?
Yeah, you can.
Okay.
That's fine. The part of the hamstrings are gonna be at the midline, and so if you pinch that, you're still gonna get some of sciatic nerves like in between, sometimes under. So yeah, see if you can come a little bit lateral.
May I do the other side?
Yeah,